So welcome everyone. Welcome to the 135th session of the online Optom learning series OOLS. And for today's session, we have with us Dr. Byki Huntjens. He is a qualified optometrist from the Netherlands and has obtained her master's as well as her doctorate degree from the University of Manchester. She is involved in teaching a variety of clinical subjects currently at City University of London, which also includes contact lenses as well as dry eyes. Her passion and her main research interests are, of course, contact lenses and dry eye. With that experience, that interest, she is also a council member for the BCLA. She holds fellowships from the BCLA as well as IACL. He is the chair of the British and Irish University and College Contact Lens Educators, known as BUCL. Recently, he has also been appointed as the board of directors at the IACL, which is the International Association of Contact Lens Educators. Yes, we do share that position. And most interestingly, she is also the educator of the year for the year 2021 from IACL for the Europe, Africa, and Middle East region. And Dr. Byki is going to talk to us about CLIDE, very interesting context when it comes to contact lens induced dry eyes, and how should we assessing it, and what should we do to manage, what should we do to address it. So welcome, Dr. Byki, onto our platform.
Thank you.
And let me leave the screen time to you.
Fantastic. Thank you so much for that very long introduction, Fakhruddin. And obviously, as I already said, all of you for tuning in. I hope you had or are having a great Sunday. And you are up for some discussion, hopefully, really, about contact lenses and dry eye. Really, my greatest passion in education, but also in research. So during this session, I will go over the definition of CLIDE and detailed knowledge of the tear film and its components, but also a little bit its function. And then I try to give you an understanding of the interaction between the tear film and the contact lens while it's on eye. And then we will discuss the effect of all of that on contact lens discomfort and see how we can manage this in practice. Before I start, here are my disclosures from the past 5 years. So it's estimated that about 140 million people worldwide wear contact lenses, and that number has actually remained relatively stable over the past decade, despite the investments really that has gone into the improvement of contact lens technology. And the reason for this lack of growth is largely because 12 to about 51% of wearers drop out of contact lens wear each year. And why is that, I hear you ask? Well, a survey completed by approximately 4,200 participants showed that the #1 reason for discontinuation of contact lenses is discomfort. And the #2 is dryness. And interestingly, you can see here from the bars, the lighter gray represents those that are younger than 40 years of age, and the darker ones over. And you can see that dryness is actually experienced by all ages, while discomfort is mostly reported by those under 40 years of age. And contact lens discomfort means that the patient is complaining of adverse ocular sensation, and that's causing this reduced comfort while wearing the contact lens. And this is an immediate result from poor compatibility between the contact lens and the ocular environment, which causes a reduction in the comfortable wearing time. So before I will go into the detail of contact lens discomfort, I was just wondering, how would you describe discomfort in contact lens wearers? So would you call it, for example, contact lens discomfort? Are you calling it maybe something like dry eye syndrome or ocular surface disease? Or are you much more specific, talking about contact lens associated dry eye or contact lens induced dry eye? Some people call it contact lens related dry eye. Just wondering about the terminology really that we're all using.
All right, so I have launched the poll and I'm getting some responses already.
I can actually see that, Fakulin. I can actually see the poll in progress, and I can see that nearly 60 of you have responded. So contact lens discomfort seems now the most common terminology used. Yeah. And then some of you are talking about contact lens associated dry eye, and others are contact lens induced dry eye. So yeah, I was kind of expecting that actually. So that's really good. Thank you. Thanks for participating in that. Well, you know, this is kind of my face. When I'm thinking about this, because when I was actually preparing for this lecture, I was kind of putting in keywords, right, to kind of get the research and to understand the relationship between the contact lens and the tear film. And you can see really from all these wordings, you know, there's so many of this. It's really difficult really to decide on the keywords. So we do need a bit of explanation of the terminology that we use. So we all have our own preference really, and there's a three main preferences, but I will talk a little bit about that because I do think it's important to understand the differences. So the TFOS International Workshop on Contact Lens Discomfort provided the following definition for contact lens discomfort. It is a condition characterized by episodes or persistent adverse ocular sensations related to contact lens wear, either with or without visual disturbances, which results from reduced compatibility between the contact lens and the ocular environment, which then can lead to decreased wearing time and discontinuation of contact lens wear. And in fact, the progression of dry eye in contact lens wearer is therefore following that process. It starts really at the bottom with this kind of like a struggling contact lens wearer who notices maybe an initial physical awareness of the contact lens and then possibly complains also of visual disturbances as well. And I think actually, unless we particularly ask about this, we might pick up the visual disturbances because we're all really good, right? We're whipping out like a Snellen chart or a Logmar chart and then trying to improve vision. But this whole physical awareness of the contact lens, we may not actually spend so much time on in our history and symptoms. And then from here, that leads on to reduced comfortable wearing time. And this is really a question we should be asking our patients. Of course, we're asking about wearing time in general, the maximum wearing time. What time did you put your contact lens in this morning? What time are you generally taking it out? How long are you wearing the lenses today? But also how comfortable on a scale of 1 to 10, for example, explaining them what 1 means and also obviously what 10 means. What is the comfortable wearing time? And then from reduced comfortable wearing time, we're then leading on to reduced total wearing time. And then if you leave that untreated, we get to the point where they start to discontinue temporarily their contact lenses. For example, they only wear them for sports or for going out or let's say for the weekend. And then obviously in the end, before you know it, we have another dropout. So for the purpose of this particular lecture, I do wish to make a clearer distinction between these certain cases of contact lens discomfort. Because contact lens discomfort is like like an overall thing that could be including all sorts of reasons for it. CLIDE, the purpose of this particular lecture, that means contact lens induced dry eye, is caused by wearing the contact lens and experiencing symptoms, while most importantly being asymptomatic after lens removal. And that is opposed to CLIDE, or contact lens associated dry eye, which refers to pre-existing dry eye amongst contact lens wearers who are symptomatic regardless of wearing the contact lens. So they have the dry eye either while they're wearing it or not wearing the contact lens. So, and the difference then also for this particular lecture is that I will focus particularly on what the contact lens itself, its effect of the contact lens itself on the discomfort, and maybe less so on the underlying dry eye problems, such as meibomian gland dysfunction. So the prevalence of CLIDE among contact lens wearers ranges greatly, similar to actually to dry eye in general. Somewhere between 15 and 55% has been reported in the literature, and there's quite a few studies out there. The rate varies so greatly between the studies because it depends on the study population. Obviously the contact lens material that is being used in those clinical studies. Also the diagnostic criteria. So for example, what type of questionnaire has actually been used to identify that there was contact lens induced dry eye. And also the clinical tests that we use in practice to identify dry eye. So let's have a look at why we are actually seeing CLIDE in practice. Well, it starts off really with the experience of discomfort or pain. So contact lenses interact with some of the most richly innervated areas of the body, such as the cornea and also the lid margin, maybe to a lesser extent the conjunctiva. And so perhaps it's not really surprising that the eye can actually detect and also react to the presence of the contact lens. And before I dive into the mechanism of CLIDE, I will just do a really quick reminder of the tear film. You probably have heard it before, so I will go through this a little bit faster. Starting most anteriorly, this is the superficial, albeit quite complex, lipid layer. Consists of this outer non-polar lipids made out of fatty molecules. And then we have the inner polar or phospholipid layer, which serves as a glue to hold the oil to the aqueous component, which is just sitting below there. And then this next layer is kind of made up from a mixture of aqueous and mucin. So the aqueous phase includes varying concentrations of secretory mucins throughout, whereby the mucin concentration is the highest the closer we are getting to the corneal surface, which you can see right here. And the inner mucin phase consists of membrane-spanning mucins that anchors to the ocular surface epithelium, more specifically the glycocalyx. So instead of the traditional trilaminar structure of lipid, aqueous, and mucin layers, we should really take more into account like a superficial lipid layer, and that's then next to an aqueous mucin gel. The lipids are secreted by the meibomian glands, which you can see here on the right-hand side. These little white lines indicate the tubulo-acinar architecture of the glands. The meibomian glands are located in the tarsal plate of the superior eyelid as well as the inferior eyelid. And there are approximately 40 to 50 glands on the top and about 20 to 30 glands in the lower lid. And here on the bottom, you can see an example of meibomian gland dropout. So the lipid layer serves to prevent the evaporation of the aqueous layer. It aids in the lubrication of the ocular surface, and it helps maintaining tear film stability. Lipid secretions contain dozens of oils and waxes and are constantly synthesized and secreted, and then they push the meibum very slowly towards the marginal orifices during the blink. And in a healthy eye, the lipid layer is minimally 40 nanometers thick. Any thinner, and then the tear stability may be reduced. The aqueous layer is produced by the main and the accessory lacrimal glands, and it provides oxygen as well as nutrients to the cornea. The lacrimal glands are responsible for the stimulated aqueous secretion, while the exocrine accessory glands secrete the basal or the unstimulated tears. Being rich in beneficial proteins, it has important antibacterial and protective properties. And it helps to flush away the debris and toxins and foreign bodies. So this kind of like this middle phase of the tear film, it also contains water, nutrients, and soluble mucins, as we already heard. And this component is approximately 4 to 6,000 nanometer or 4 to 6 micrometers thick. And then the role of the mucins, that is really the lubrication of the ocular surface and ensuring that the tears spread even over the anterior ocular surface. And mucins make the superficial epithelial cells of the conjunctiva and the cornea wettable. And they provide lubrication and form like a physical protective barrier against pathogens. A reduction in mucins makes individuals more susceptible to infection or disease. And mucins are produced by the bulbar and palpebral conjunctival goblet cells, surface epithelial cells of the cornea, as well as the lacrimal gland. And goblet cells are particularly abundant throughout the conjunctival epithelium of the tarsus and the fornix. The mucin component of the tears is approximately 500 nanometer or half a micron thick. So the tear film performs several important functions. So it smooths out any irregularities of the corneal epithelium, and then it creates like an even surface of very good optical quality. The cornea is avascular, so it's dependent on the tear film for its oxygen supply. And the constant turnover of the tear film also provides a mechanism for the removal of metabolic waste products. And as we already heard, the tears play a major role in the defense of the eye against microbial colonization. The tear film also acts as a lubricant, smoothing the passage of the lids that will go over the corneal surface, and relatively high viscosity of the tears aids stability between the blinks. But interestingly, this viscosity falls dramatically during the blinking process. And that reduces friction and eases the movement of the lids over the ocular surface. So the core mechanism of CLIDE involves the partitioning of the tear film into a pre- and a post-contact lens film. So here on the left, you can see the tear film without a contact lens. And then on the right, you can see what a contact lens does to the tear film. So the pre-lens tear film is shown here on the top, and here the post-lens all the way at the bottom. And then in between represents a soft contact lens with a typical center thickness of 70 microns. So in a healthy eye, the tear film thickness is about 3 to 5 microns. However, once the contact lens has settled on the eye, and please remember, as soon as you take a contact lens out of a blister, that's quite wet, so you are adding actually quite a lot more tears to the eye. But once the contact lens has settled, the pre-lens tear film is only about 2 to 3 microns, and the post-lens tear film probably 1 to 3 microns. And this post-lens tear film is actually, it varies quite considerably in thickness, much more than the pre-lens tear film. And this is possibly due to the relationship that it has with the posterior lens surface and the corneal surface, as well as the lid pressure. So factors that may have an impact really are the radius of the optic zone as well, the lid aperture size, and the lens modulus. Contact lens discomfort can be caused by the contact lens as well as its environment. And in this talk, I will mainly go into, in fact, I wanted to talk about everything, but I realized I need about 2 hours. So I don't want to do that to you. So I'm going to focus mainly on what the contact lens itself what the effect is of the contact lens itself on the dryness, on CLIDE. So for completeness though, environmental factors can also increase the risk of CLIDE, including an increase in temperature, coupled with reduced humidity, and prolonged use of a computer or near work, Females are more likely to experience CLIDE than males. And there have also been some racial differences in CLIDE, actually, that were reported that whereby Asian contact lens wearers have more severe dryness compared to non-Asians. So let's have a closer look at how the contact lens itself affects CLIDE. I do want to point out, though, that it is difficult to measure these in isolation because changing one factor in a contact lens or a care solution can invariably affect all the others. I use a bit of coloring in the next couple of slides to, if it's green, then that represents really that there is sufficient evidence to this date. Red implies that there is no correlation with CLIDE, while gray remains that it's currently unknown. So, soft contact lens wearers have a higher incidence of GLIDE compared to rigid corneal lens wearers. Evaporation of the pre-lens tear film in a rigid contact lens may have less impact on dry eye symptoms when compared to soft contact lenses because of its material properties. Similarly, CLIDE has been more frequently reported in hydrogel compared to silicone hydrogel contact lens wearers. And high water contact lenses have also been proposed as a potential risk for CLIDE, but probably as a consequence of contact lens dehydration and local thinning of the overall tear film. Of course, this is all dose dependent, which I just put on as an extra point. In other words, there is a positive correlation between the severity of CLIDE and the contact lens wearing time. Wettability of a contact lens material involves the ability of a liquid to kind of spread out and then maintain contact with that surface. So when a contact lens is placed on the eye, the tear film and the air start to kind of compete for the contact lens surface. And so the extent of the surface that is covered by the tear film reflects the wettability of this lens material. And poor wettability, particularly the inability to maintain wettability throughout the day, that has been strongly linked to dry eye symptoms, but it is highly dependent on a variety of factors, including individual tear composition, blinking, and then related to tear evaporation, ocular temperature, as well as the type of the contact lens material that was worn, the duration of the lens wear, as well as the lens replacement schedule. Now, is oxygen transmissibility, so DK over T, a key factor in contact lens discomfort? Now, while you might think that the increased comfort of silicone hydrogel lenses is attributed to the higher oxygen transmissibility, a host of other confounding factors really will drive that comfort response. It is very important to remember that to date, there are actually no level 1 evidence studies that can provide an answer to the question of whether oxygen levels influence comfort. What we do know is that where lenses of higher DK over T are found to be more comfortable than lenses of lower DK over T, there are deficiencies in the experimental design and maybe even inadequacies of the control lenses that prevent a definite attribution of such differences to oxygen. And there are circumstances where lenses of lower DK over T have been found to be more comfortable than lenses of higher DK over T. So really, it is not actually a simple correlation. And then comfort differences may exist between higher and lower DK over T. Sometimes these were statistically insignificant, but really the method that was used to measure comfort may actually not be sufficiently sensitive to detect those differences. So I put this parameter in red. The modulus of the contact lens material has less effect on discomfort as we might believe. So I added that actually in gray. I'm not sure, there's a question mark behind it. The higher modulus of the silicone hydrogel materials was initially seen as an issue when we refitted hydrogel wearers into these more oxygen permeable materials. But now the modulus of these latest generation of silicon contact lenses is very similar to the medium and high water content HEMA materials. So until now, no study has actually been able to predict contact lens induced dry eye by the contact lens modulus. Let's have a look at the design of the contact lenses. So thicker edges, which tend to be the rounder ones, they provide poor comfort. We do know that. And it's possible that the thinner edge designs are sitting kind of like closer to the bulbar conjunctiva, so they have less interaction with the lids. The thinner designs of contact lenses, in general, the thinner contact lenses, are of course related to modulus as well as water content. So adversely, it's kind of difficult to isolate that in clinical studies. While the modulus is a specific material parameter, the effective stiffness of a contact lens will also be influenced by a specific geometry, so the lens thickness profile. And so a thinner lens made from a low modulus material will drape kind of over the cornea and distributing itself fairly evenly over the ocular surface with minimum interaction. So that's the thought behind it. A questionnaire of nearly 1,000 contact lens wearers in the UK found that CLIDE occurs more frequently in toric, 43%, compared to spherical lenses. It was about 30%. So, but to this date, for example, multifocal contact lenses have not, do not seem to have that similar effect on comfort. CLIDE is more frequently reported by those wearing conventional silicone hydrogel compared to disposable silicone hydrogel. And although we do know, moving on to the base curve, we do know that excessive movement will induce discomfort. The design and the fit are very difficult to compare between the lenses. So just saying that a flatter base curve will induce more discomfort it's actually not so clear. So because many clinical studies compare lenses of different materials and designs, and those have a bigger effect on the comfort than the base curve itself. And you probably already know that actually when you fit soft contact lenses, we know that the base curve has a very poor correlation whether or not this lens fits well or not. We have to probably look much more towards the sag and the diameter of the lens. And then moving on to the diameter, smaller lenses, they will result in an incomplete corneal coverage. They will cause also discomfort. And it's also possible that some lenses are uncomfortable because they tend to shrink a little bit when you take them from room temperature to eye temperature. And because they become a little bit smaller than expected when you place them on eye. Internal wetting agents are hydrophilic agents to aid wettability. We can also see more wetting agents that have been added to the solution in a blister pack, for example, which enhances comfort on insertion. But CLIDE, obviously, which is long-term and end of day, doesn't really fall in that category. There is inconsistent evidence that re-wetting drops or lens care solutions even on their own can significantly impact or maintain lens wettability for individual during the wear. So there are quite a few studies that look at very short-term effect, but long-term, full day, multiple days, weeks, that is not very clear. So it suggests that the presence of a lens itself and or the quality of the individual's own tear film may be actually the predominant factor. Even though we do know that a combination of products or combination of wetting agents actually perform better than others. So there is evidence to suggest that this helps, but we don't know actually its effect on CLIDE. However, lens care is very important. Maintaining clean lenses, obviously reducing the number of deposits, and those are greatly associated with CLIDE. So I would definitely put that in green. So let's have a look at how we would assess CLIDE in practice. I split it up really in signs and symptoms, starting off with the symptoms, so we all know what we're talking about. The CLIDE symptoms are very variable. They increase, obviously, with prolonged contact lens wear. Typically, symptoms may include, but they are actually not limited to, blurred vision and a reduction in the quality of vision, foreign body sensation, dryness, ocular fatigue or eye strain. And as I already said, it's common to see that increase over the day while the patient is wearing the lenses. Now, since there are so many symptoms which could indicate CLIDE, I'm actually wondering which questions would you ask your patients? Are you focusing mainly on wearing time? So if it's comfortable, or if the total wearing time maybe is reduced, or maybe a combination of both? Or are you following the JUICE 2 diagnostics protocol for dry eye and ask the 9 triaging questions? Or have you introduced a dedicated dry eye questionnaire like the OSDI, for example? Or are you currently using like a really specific contact lens related dry eye questionnaire? I can see some of the results already coming in. Very fast you guys are. Great. Love the engagement. Well done.
Okay, so I'm just gonna end this poll here.
Yeah, I can see that's brilliant. You know, we're all, I guess, you know, like, and it kind of comes back to the, it would actually be really interesting to see if this is different once you are working in practice or when you are still a student, because I guess the questions about the wearing time, comfortable wearing time, total wearing time is something that we all teach. I think Facultin is teaching that, I'm teaching that, we're all teaching that. And then once you get into practice and you can see the dropout happening in your clinic, you probably are going to wonder, like, am I supposed to be using maybe another type of questionnaire? Thank you so much for sharing those your results. Fantastic. Yeah. So I think you know, asking standard questions as part of your contact lens clinic will pick up any patient that is sitting in that initial stage of CLIDE. You know, like there is this, it's kind of like a chicken and egg problem here, because are you going to constantly ask about it, or are you going to wait till the patient is actually having symptoms so you can then address the symptoms and manage that? Or are we going to manage the patient while they don't even have the symptoms? It's kind of like this problem, right? Because you want to be as early on as possible. So this slide looks, by the way, a little bit busy. I'm quite happy to just share these links with you later on, but it is actually interesting to start incorporating maybe a validated questionnaire, so you will be able to act sooner and hopefully prevent dropout, right? Because I am still surprised how much dropout there is, considering the investment of manufacturers in producing newer materials, newer designs. So maybe there's something that we can do as clinicians. So although these particular questionnaires, this list is not exhaustive at all, these are all good. There are pros and cons to all of them. Let me just go just really short over it. So there's a speed questionnaire, which was designed by Tier Science. It's very quick. And what it does, it takes fluctuations of dry eye symptoms into consideration. So, you know, it talks about in today, in the last 3 days, and over the last 3 months. So that's an interesting to see when the patient is actually experiencing issues. This is a little bit blurry. I'm so sorry about that. The contact lens dry eye questionnaire has 8 short questions, and it's able to assign a category of CLIDE positive, CLIDE negative, or marginal. So that would be really helpful, because you can also, you know, see over time any change. And you could decide that you're going to manage particularly those with a CLIDE positive, obviously, and maybe those are already sitting on the marginal. The Berkeley dry eye flowchart, that's specifically designed for CLIDE. It categorizes individuals into one of 5 CLIDE categories based on the presence or the absence of dryness sensation during the contact lens wear, the perception of discomfort, and the frequency in which the dryness symptoms interfere with daily activities, for example, reading or using a PC. And the OSDI is obviously very well known. It's not specifically for CLIDE though. But what is really interesting about this particular questionnaire is that if you're interested in patient health-related quality of life, this is definitely the best choice for you to use. So the type of discomfort will also help you to decide on a possible management trajectory. So for example, if your patient is experiencing dryness, grittiness, or scratchiness, those are terms that patients quite frequently use to describe any discomfort associated with the movement of the upper eyelid over the ocular surface or over the contact lens. So if grittiness and scratchiness occur with blinking, it indicates that the tear film is inadequate to lubricate the lid wiper, and then you end up with a lid wiper epitheliopathy. I will talk a little bit about that later. Then you could also, your patient could also experience soreness or irritation, maybe a little bit less specific, but it can arise from various conditions such as, for example, allergy, inflammation, or minor infection. On its own, this symptom group adds little specific diagnostic value, but then when you present it with clinical signs of dry eye or in conjunction with other dry eye symptoms, this strengthens your case that there is a problem with dry eye. And then burning and watering often suggests there is some sort of like a degree of ocular surface exposure, and particularly between blinks. These symptoms might correlate with a reduced breakup time in the form of insufficient tear formation or very high tear evaporation rate. So when tears evaporate more quickly than the interblink interval, then the lacrimal glands will start compensating by increasing this rate of production. This is something that I'm terribly suffering with, hence my glasses. What about signs? Which signs do you primarily look for? I wonder. There is no right or wrong answer, by the way. I'm really just interested. What's your thought process? Are you looking particularly at, for example, staining? Or are you looking at tear prism height, breakup time, whether or not you do that with fluorescein or without fluorescein? Or are you really looking already more like towards the anatomy of the lid? So you're looking for meibomian gland dysfunction, or have you got like some fancy kit and you are using all the time the tear osmolarity, for example? I can see already actually from the results that the tear osmolarity is not the one that is very popular, even though it is part of the dry eye, the TFOS juice 2 definition of dry eye.
Yeah, that's right. So you have gotten... Yeah,
breakup time. Yeah, definitely. You know what? It could be that my students are replying like this because I'm guessing this is what they would say. Yeah. You know what? I think all of it is good. You know, like everything that you are answering is great. I won't talk that much about meibomian gland dysfunction because it is a pre-existing dry eye. So particularly for CLIDE, and I know that that's not how you work in practice. You're not going to look just for CLIDE. But if we are looking for signs and we are wondering if there is CLIDE, then yeah, most of these will be what you will see in practice. So let me just show you what the literature has found. So the role of the lipid layer is to decrease surface tension and inhibit tear evaporation. And by splitting that tear film into a pre and post lens tear film, the contact lens reduces the aqueous layer thickness, and then that causes then an impact on lipid layer thickness and uniformity. And then that leads to increased deposition and then pouring, wetting. And then it has also shown to correlate with symptoms, obviously, of contact lens discomfort, including CLIDE. Tear evaporation rates, they are known to increase in the presence of an incomplete lipid layer. In healthy eyes, the contact lens induces an increase in tear evaporation rate, regardless of lens material, even between RGP and soft lenses, to be honest. However, higher tear evaporation rates have been found to cause decreased comfort in new wearers, particularly if they're fitted with hydrogel lenses. It's something to keep maybe in mind. Under normal environmental conditions, no relation between tear evaporation and discomfort has been confirmed, but under adverse conditions, for example, low relative humidity, an increase in tear evaporation rate has been associated with discomfort in hydrogel, but not silicone hydrogel lens wearers. With regards to the aqueous component, an average tear turnover rate of 15% per minute is typical in a healthy young subject without a contact lens, but these tear turnover rates decreases significantly when you insert a contact lens. And that becomes about 12% per minute in hydrogel lenses, which is only slightly better in silicone hydrogel lens wearers. I'm not quite sure how you, or if you measure tear meniscus height. It's very useful when you're looking for aqueous deficiencies. You can use a variety of fancy equipment, automated analysis, but like I do in university, and you might do also in practice, what you can use is a slit, an illuminated slit set horizontally, aligned with the lower lid margin to match the height of the tear prism. Contact lens wear directly impacts tear meniscus characteristics. Compared to without contact lenses, the lens wear significantly reduces the meniscus or the tear prism height by approximately half. A reduction in goblet cell density has been observed with hydrogel contact lenses. Secreted mucins are reduced at the ocular surface, and this may affect lens comfort during contact lens wear. There is a compression and a thinning of the ocular surface glycocalyx layer. However, other studies reported no effect or even increased in goblet cell density. So there are discrepancies, and maybe these are due to the use of different lenses and the collection of cell from different areas on the conjunctiva. So it's not that clear. Lipid layer quality and tear film stability are closely linked. Therefore, with contact lens wear, we see a reduction in the stability associated with the reduced aqueous layer thickness induced by the splitting of the tear film. This is then reflected into a reduction in tear breakup time. Here we go. We are expecting over 10 seconds in a non-lens wearer, but that reduces to about 2 to 3 seconds with a rigid contact lens and about 5 to 6 seconds with hydrogel lenses. Hydrogel, I mean soft contact lens wearers, regardless of the material. During contact lens wear, blink frequency increases to compensate for this reduced tear film stability. Incomplete blinks, more commonly found in higher water contact soft contact lenses, has been associated with breaches in epithelial integrity that we also known as epithelial desiccation. I will talk a little bit more about that in a few slides. And that will then obviously cause discomfort and increased lens deposition. Lissamin green, I'm not quite sure if you guys use that, but it's able to identify epithelial cells without surface glycocalyx. So it's very useful, particularly in dry eye. Anatomically, the Marks line defines the transition between the palpebral conjunctiva and keratinized eyelid margin. So the Marks line stains with lissamin green, and you can see that here on in this picture. And the degree of staining of the lid wiper region reflects the amount of physical trauma to this eyelid region. So you see here that this becomes a little bit thicker And so we're looking for the area that is all stained with lissamine green. Lip cough or lid parallel conjunctival folds that you can see here on the right, they are an indication of ocular surface dryness, and as a result of their location immediately next to the lid margin, this can compromise the formation of a normal tear reservoir. And both lid viper epitheliopathy as well as lip cough can be increased in soft contact lens wear, and they have been associated also with discomfort. CLIDE may result in hyperemia in severe cases. These days, with the modern contact lens materials and designs, we do not really expect to see severe bulbar hyperemic changes in CLIDE. However, hyperemia is sensitive and an indicator to physiological impact of contact lens wear. So I would recommend that we keep monitoring these changes during contact lens wear. Characteristic staining of the corneal epithelium can result from desiccation staining, which we can see here on the left. Nocturnal lag of thalamus, so if the eyelids don't really fully close at night. And on the right, we see a pattern that is very consistent with solution sensitivity. Desiccation staining occurs in location where the tear film is the thinnest and or the least stable. So soft lens smile staining that we see that occurs parallel and adjacent to the lower lid. Low levels of desiccation staining may be tolerated because they can also be present in a normal or a non-lens wearing eye. However, low to moderate levels of corneal desiccation staining can be mitigated if you improve blinking, if you use wetting drops, or you reduce the wearing time. It is well known that tear pH decreases in contact lens wear with reduced tear exchange, but evidence associating this with contact lens discomfort is actually lacking. So discomfort might be experienced by wearers if the pH of the ophthalmic solution, so for example the blister or the solution in the blister or the care regime or the drops that you use as an external wetting agent, if that falls outside the range of a normal physiological human tears pH. Currently, there's no available data on the effect of contact lens wear on tear viscosity, nor any association with discomfort directly. Similarly, surface tension in contact lens wear has not yet been explored really, so no association with comfort has been demonstrated. That being said, it is known that the tear biochemistry is affected by contact lens wear, so it's plausible that these changes could contribute to alterations in surface tension. And as a result of aqueous changes, we may also find changes in tear osmolarity during contact lens wear. And that is a big thing for dry eye in general. So pre-existing dry eye, we now know we focus on tear osmolarity. But what about CLIDE? So osmolarity is an objective measure to measure like the salt concentration in a patient's tears. And these changes in osmolarity are due to fluctuations in water content, not tear composition specifically. The balance of the proteins and the lipids and the mucins in the tears remain actually stable, but it's more the fluctuation of the water content. So osmolarity was found to be significantly increased after 3 months of hydrogel wear, possibly related to increased tear evaporation. However, in adapted lens wearers, results are not actually that consistent. So any findings regarding the effect of the contact lens discomfort on osmolarity is also conflicting. So really, in summary, we could say that we know that CLIDE reduces tear breakup time, tear meniscus height, it increases corneal epithelial staining, as well as lid viper epitheliopathy and lip cough, potentially. Increased blink rate and ocular surface inflammation that may occur depending obviously on the severity of the condition. But to date, the effect on comfort on many of the other biophysical properties is actually unknown or inconclusive. So we do need further evidence to establish whether pH, surface tension, or osmolarity has a direct link with CLIDE. Now, how will we manage that? Let me just quickly have a look at the time because, yep, okay. Just a few more slides. The management of CLIDE includes treating pre-existing ocular surface disease that may contribute to tear film dysfunction. But please remember, in CLIDE, patients are complaining of dry eye while they're wearing their contact lens, but this actually is not present once they remove. So they will probably, if they have any pre-existing dry eye, they are not actually experiencing any symptoms with that, because otherwise they wouldn't have CLIDE, and you would normally classify them as CLIDE. However, we do also know that dry eye itself has a very poor correlation between signs and symptoms. There are people who have got loads of signs and no symptoms whatsoever, so they're not actually coming to see us. And you might pick them up accidentally by looking at the cornea and the anterior surface and the lids. So it is really important that we do consider if there is any pre-existing ocular surface disease, and this approach includes anything that you would do also in non-contact lens wearers. So are the deficiency present in the lipid layer and the aqueous, the mucin layer? So consider which kind of subtype of dry eye disease you're dealing with. So you could look at evaporative dry eye, aqueous deficiency dry eye, much less common, obviously, and then or a combination of the two. And then decide the treatment plan depending on the severity. And I'm not sure if you are aware, but if you might be aware, the TFOS used to has set out an algorithm to help you identify how to manage these patients. And so if you don't know about it, please download a free copy. You can just Google it. Now let's have a look at treatments targeting the contact lens. We may want to include switching to silicone hydrogel contact lenses, using contact lenses with a higher wettability, or possibly applying external wetting agents for the right purpose though. So for example, if you want to apply external wetting agents to improve or support the lipid layer or the aqueous layer, that could work. Whereas at the moment, wettability of the contact lens itself may actually is probably the way forward. So the material, the wettability of the material has a bigger effect than the internal or external wetting agents that we could add to it. So your better bet would probably be just to look at the wettability of the material. Similarly, switching to daily disposable contact lenses can be helpful. Scleral lenses actually may also improve symptoms of dryness and protect the ocular surface in patients with pre-existing dry eye disease and CLIDE. And then the prevention and advice to contact lens wearers. I think it's important that we communicate this more. You know, if you ask a patient how are you doing with your contact lenses, and they say, oh, everything is fine, and you just take that as a given, and you don't ask any further questions, then you might actually be missing out those that are already at the beginning of the first steps, let's say, of the progression into dropout. So some tips really. I really would recommend that we explain CLIDE and that we are aware and make the patients aware of the risk factors. Make sure that you and your staff are obviously up to date with the latest advances in contact lenses. That might be quite a big ask, depending on how many contact lenses that you currently stock. But don't assume that the patient is just happy when they report no problems with their contact lenses. As I already said, use careful questioning, or maybe even just a standard question, particularly for contact lenses, related to contact lenses, because otherwise you're going to end up asking all these questions about dry eye, which are not necessarily related to the contact lens, and it becomes quite difficult to manage all of that. And try to keep up to date with the new products and the new technologies, and talk to your patient about that. Just, don't assume, for example, also that patients can't afford a better performing product. So in summary, the tear film is highly specialized, and it has a number of crucial roles in maintaining comfort and vision, as well as the health of the eye, because we can't really prevent contact lens tear interactions. So maybe the best approach is to just work with this interaction and aim to integrate and mimic like key helpful components in the contact lens itself. So what we want to do is we want to have all of that result in a low level of inflammatory response and maintain low levels of coefficient of friction, and that maintain a stable tear film, and then obviously also stable vision for the contact lens wearer. And I'm actually really looking forward to see where the future takes us on this. We can see more and more equipment coming out, more imaging techniques to help us understand why, particularly how the lids are supporting contact lens wear. I just have a couple of resources, mainly the TFOS workshop, obviously, as well as the CLIDE reports. I'm not sure if you have already downloaded it. I'm sure you have seen some on social media about it. There is a link here, which I'm happy to share in the chat box, where you can download them all. So go for it. And yeah, thank you for listening. And don't forget, it's Dry Eye Awareness Month.
All right. I think that's, thank you so much. And thank you for sharing that with us, that it is a Dry Eye Awareness Month. I was not aware, to be honest. And thank you so much for letting me know.
Great. That's fantastic. That's always really nice that, we always learn something, don't we? This is why these webinars are so interesting. Like I attend as many as I can, because it's lovely to hear what people are doing and their speciality. And I hope that everybody came out of this thinking, oh, that's interesting. That's what I would like to apply to my clinical practice.
So the first question here, Dr. Byki, is any particular time of the day, specifically, have you experienced that patients report these CLIDE symptoms, or anything you would like to add on this particular topic?
Yeah, that is a very good question, and I wish I had a very clear answer, like for example 5 or 7, and unfortunately it doesn't really work like that. I do believe that obviously CLIDE happens more towards the end of the day. So we are experiencing more dryness the longer we have the contact lens in, because again, with CLIDE, it's really about the dry eye that is induced by the contact lens. So once you start wearing that contact lens, you get some dry eye experience. And normally that takes a little bit of time because the lens will settle first. And initially you will have enough tears, if you have any particularly dry, a pre-existing dry eye, that will obviously become quite short. This is the issue where dry eye, having pre-existing dry eye and non-pre-existing dry eye, that's a problem, because I already mentioned that not everybody experiences symptoms, even though they do have dry eye. And I think that is a difficult why, the classification of CLIDE versus CLIDE is actually quite difficult. And you might change somebody, you might think, oh, this is CLIDE, this is definitely because of the contact lens, because as soon as they take it out, they don't have any more issues. And then actually, as you then look into dry eye and you're using the TFOS juice to diagnostic way of finding out what type of dry eye they may have, you may actually find out that they have evaporative dry eye, but they weren't complaining about it. And they don't complain about it even after you tell them. So because there's a very poor link, I cannot really tell you the hours, but I would expect the longer, longer in the day, later on in the day is CLIDE, and you will notice those that have more severe CLIDE, that will drop down, and then they get to that point where they start to wear their lenses temporarily. they're reducing their wearing time. So what I would recommend, I actually didn't put that on a slide, but most of you, when you were voting about what do you use in practice, which kind of questions do you ask? I think the really important one is this comfortable wearing time, and keep a track of that, right? Keep a track, look back as well. Like, you ask the questions, but are you actually checking what they said the last time? So what is the wearing time? Have they already reduced their total wearing time? Do you see a general decline of the comfortable wearing time? Then, yeah, it's time to spring into action.
That's right. Yeah. So
very long answer, sorry.
yeah, I think that's really important in when we are questioning. I think we need to change the question. Maybe as you are mentioning, the question should be, how many hours do you comfortably wear the lens versus how many hours you wear the lens. It's a big difference, and that can help us probably to come to some conclusions, right?
Yes, and Fakhruddin, the other thing actually is, how long do you want to wear the lens?
Yes.
Because actually, the people say, oh, I wear the lens 12 hours. And I was like, that's fantastic. But actually, my day is by far longer than 12 hours. Is that now, are they saying 12 hours because they've been taught that during their teach? Are they honest? Are they giving us the answer that they think that we want to hear? That's why I always like to ask, what time do you put your contact lenses in? And what time do you take your contact lenses out? And then it's all the math up here to figure out what actually the time is, because they might just tell you 12 hours because they have been taught that, during the teach. Or they read it somewhere, or they were told off by your colleague.
That's
so,
true.
yeah.
So I think this information, getting the information correct from the patient really helps, right?
Yeah, needs to be an open conversation. What is it that you want? Can I supply that for you? Can I find that for you? It needs to be together. We need to do it together. Otherwise, they're not coming back. You see, I don't know about you guys, but, we see a lot of patients buying contact lenses online.
Yeah.
And how can we make them come back if we are going to be there with a stick and a red pen and oh, you can't do this and you can't do that? That's not how it should work. Yeah.
Yeah. All right. Let's look at another question. Why do some patients report that they are comfortable with a particular brand A compared to the brand B, but both brands claim that they have good wettability?
Yeah. The claims are always really nice, right? The claims that it's good wettability. Yeah. And I have to say that that's a very good question, by the way. So if there are units of wettability and the wettability units look the same, in other words, you would expect that the same lens or certain lenses should have the same response in the patient eye, and they don't, then clearly there is something else. There is a certain part of the material that is less compatible for one patient versus the other. Now, it is possible that you have a very good wettable material, but for example, one material will attract more lipids or will attract more proteins than the other one. So you can have a deposition on top of the lens, which actually makes that patient say, I don't like this lens gets greasy or it gets dirty. So even though the material is wettable, it is possible that it will attract certain components of the tear film more in one another. That's just one example that could happen. Then you have obviously also the design takes as we heard, there are so many different reasons why contact lenses are comfortable or uncomfortable. So it can have to do with the design. If it's a reusable lens, are we using the correct solution that goes with that contact lens, or are they just buying their own solution that is not compatible with that material? God, there's so many reasons. Yeah.
That's right. Yeah, this question particularly was for a daily disposable lens. I just put as brand A and brand.
Oh, yeah. Oh, okay. So not the reusable then. Yeah, sure. Fair enough. But I guess it has a lot to do with the design, with the fit of the lens, like how it maybe there's some shrinkage. Oh God, there's so much going on. I think we are trained to be optometrists and contact lens experts, right, in practice. But for some reason, we kind of always want to have like a one answer, and then there isn't any. And actually, that's the cool thing about our profession, because otherwise our profession would be nullified. There's no need for us. You could just put a patient behind a computer. They will do, it's a very simple algorithm. It's not like that, is it? It's never like that. And that's the beauty of our profession, because we keep seeing these patients, and because of age, they will change, the hormonal things change, everything changes, refractive changes. So we have always got work to do, but it's never simple.
Never a straightforward answer. That's true. Yeah. Let's look at another one. Anything I think you did mention also this one, but anything would you like to add on the mechanism? Probably, how does high water content material induce?
Yeah, that is a very, very good question, and very basic thought about what materials can actually do to a patient's eye. And I'm going to say it in a very simple way. And please factor it in if you want to jump in, please do so. When a contact lens, a soft contact lens, this is why there is so much difference between rigid and soft contact lens. But in a soft contact lens, if the material contains a lot of water, it also means that there is a lot of evaporation, because every time you have your eyes open, the water from the contact lens is evaporating into the air, same actually as with your tears. And when that happens, when the water from the contact lens evaporates, and if you have a lot, so if there's a high water content material, there's a lot of water and it can evaporate, it changes actually the curvature of the contact lens, and it becomes a little bit, you can feel that lens, it almost like it shrinks a little bit. And to prevent that shrinkage, the contact lens will then suck up your own tears to kind of maintain its shape. And to do that, so then suddenly you end up with a nice contact lens, but you have very few tears yourself. So it's kind of this constant cycle of production of tears, evaporation of tears, and then from the contact lens, and then the contact lens is kind of taking your tears up into the contact lens to maintain its shape. But you can actually feel the lens, because the evaporation is quicker probably than actually sucking up all the tears constantly. So you can feel that contact lens. So it becomes a little bit uncomfortable. That's what discomfort actually is, what patient, most of the discomfort. I'm not talking about the lid margin and, going over the thing, but if we're just talking about water content, yeah,
that's right.
That's how I would explain it, simplified.
Yeah. Great. And how often would you advise follow-up visits for your patients who have any protocol you follow or advice when we should see them?
Yeah, that's a good question. Also not very simple, but it depends a little bit on the patient, and it depends on the severity. So if we have a CLIDE patient and I identified that I need to refit them, then obviously they will go into the normal, let me just go back. If I identify CLIDE, I'm going to do something about it. That's my first action. Because if you identify CLIDE and just write it down on your record card and then see you later, alligator, that's not going to help. Like the next time you see that patient, or you might never see them again, but the next time you see that patient, they are already into that progression towards the dropout. So I don't want that. I need to action now. So I'm probably going to refit. And that's when you are going to, you will ask your patient to follow the normal protocol for refitting of the contact lens. So that's probably my simplest answer. Yeah, I'm not following them up quicker just to monitor CLIDE. That's my main answer. I don't monitor CLIDE. I action it. I need to do something. Yeah.
Yeah, you don't want them to get to a dropout stage. You want to prevent that. So act now and solve their problems now, right?
Yeah. Particularly if they were the ones that were complaining about, if they're struggling, then we need to do something, no? Because if they're not struggling and you haven't identified CLIDE, then fair enough. You see them again in 1 year, 2 year, whatever your protocol is for seeing your patients on a follow-up. But once they start saying, actually, I can physically feel, or you're using a questionnaire and you identified marginal CLIDE, then it's time to start talking about things. And I'm not saying that I am forcing a refit. Sorry, I have to be clear about that. I'm not forcing a refit, but I'm definitely going to explain where this is going to lead to if we're not going, springing into action now.
That's right. And I think, as you said, once you take the action, then the follow-up remains as you do the action. So, for example, if you refit by a next soft contact lens, you will follow the aftercare as you do for a normal soft contact lens, right?
Yeah, and it's really nice because I noticed that particularly in the dry eye clinic, so this is not particularly for contact lenses. I really noticed that patients are they react very positively when you explain to them that they're on the right track. So in other words, for example, you did a questionnaire and your results were X, Y, Z. And then the next time we are refitting you now, we've made a decision, we're going to refit, we're going to try something else to improve you. And then they try that out for like, whatever, 6 months, 3 months, whatever. And then they come back and they do that same questionnaire and you can compare the results. So make them part of your decision-making. It takes more time. It takes more time. I think we're used to somehow to think that we can just do contact lenses quick. And I think we are shooting ourselves in the foot if we don't start spending a bit more time with our patients, discussing these things, to keep them. I mean, 50% dropout, all that work that you did in explaining contact lenses and the teach and the fitting and the seeing them multiple times. And then after a year, half of your patients will not come back.
That's true.
No.
It's really important that patient education here,
Yeah.
You said patients must be educated, and I think that's the key, so that they understand. You as clinician, of course, understand, but your patients must understand as well.
Yeah. I think communication on its own is a whole thing, isn't it? In fact, I think actually, if I'm really honest with you, you learn communication most in clinical practice. So teaching that at university is really difficult. Yeah. And I very much, I'm very aware of that, particularly in contact lenses. In university, you don't really see the, enough patients really to learn about communication.
Yeah. All right, let's look at another question. How could we help, or what is the best management to increase wettability? And
wow.
Question here is, do you think there is role of artificial tears in helping to increase wettability? Just a question there.
Yeah, it's a good point actually. So I'm not quite sure, faculty. Do you have so in the UK, we have a contact lens manual that shows us all the contact lenses and everything that they, the DK over T, which radius they're available in, which powers, and everything really. And it tells you also a little bit more about the material. So which group do they fall in? And that's really helpful. So you can actually really quickly, using that book, you can really quickly look at what are they wearing now, which group of contact lens material, 1, 2, 3, 4, do they fall in? Is it ionic? Is not? So you can kind of figure out a little bit about the material itself. And then you could potentially say, actually, I'm going to try to go into a different group because I know this particular group will attract more of these deposits and it will have this effect that has, more water content, less water content, all that kind of stuff. So that's really helpful. That's the first thing we probably would do. However, if we're looking at external wetting agents, I am very much for being very targeted because I know, you probably have the same at home, but here, if I go to a pharmacy, I literally get a headache looking at at least 50 types of eye drops that are out there for patients just over the counter that you could just take it and pay for it. And it just depends on the color of the box or the nice lady on the box or whatever, somebody smiling or whatever is attracting you that day to buy that particular. So we need to be really specific in telling our patients what type of eye drops, wetting agents, external wetting agents, we would prescribe to them. So yeah, there are certain things that I would do as part of and I'm kind of applying from the dry eye clinic. So if there is a lipid deficiency, then I would look more towards a lipid enhancer. If there's a patient who doesn't have a sufficient amount of tears, so an aqueous deficient, I would look for a different type of and I just have in my head, these are the ones that I would use, right? And you have to keep up to date a lot with this. It's a lot of work, to be honest, but there is a directory of dry eye drops. A lot of these are actually not necessarily for contact lens wearers. This is a problem.
That's right, yeah.
So how I think you as a group of practitioners could help is to make together a short but evidence-based directory of lipid enhancers, mucin enhancers, eye drops, and then decide when the patient needs a certain eye drop, this is the one that I would prescribe for contact lens wearers. I am not really 100% sure. Now there's more and more of these drops available on the market. So I don't know if the same that are on the market here in Europe are the same in the market where you are practicing. So you will need to do it, but I would do it together with a group. In fact, Fakhruddin, it's a really nice student project.
Yeah, that's great. And I think with these drops also, again, it all boils down to patient education. We need to tell patients, I think, when we're communicating, right? As you said, when you walk in a pharmacy, you see that whole, rack of eye drops, and people tend to pick out either the cheapest option, that's natural, or somebody looking nice offer, and maybe they are not compatible with the material. So instead of solving the problem, you might aggravate the problem,
Yeah.
So important as well.
Yeah. So I mean, the main comment for me would be preservative free.
That's right. Yeah.
So having like the little minims so they can use it during the day if they need to, put the cap on and then throw it away at the end of the day. Not having a bottle that is open for 6 months and just you're carrying around like a bottle of bacteria. And also because the preservatives may actually have an effect on the dry eye again. So it's a nightmare. Yeah.
Okay, a couple of more questions here. This is again regarding the advantage of daily disposable lenses compared to bi-weekly or monthly disposable with regards to CLIDE management. So is it something which you would always offer patients to go in for daily disposable lenses? Is there something you would like to add on this?
No, I think that's a very interesting question as well. My God, you guys are on fire. I think that so it has been shown that CLIDE is more common in the reusable lenses, but I don't think that means you should put everybody on daily disposable. So that's my first thing. I think what you need to remember is that if a patient is experiencing CLIDE and you are trying to improve their experience of their wearing time, their comfortable wearing time, and you don't want them to drop out. The idea is that you are looking at if your contact lens is evaporating all this water and the patient doesn't have enough tears themselves to keep the shape of that contact lens, then maybe going from a high water content to a lower water content may help. Going to a silicone hydrogel versus a hydrogel may help. And going to a daily disposable versus a reusable may help. Now, the reusable one, I have to say, I put it all the way down in the list as well in my slide because I have to be honest, I don't think you have that option very often because A, it could be a financial issue, but B, it could very often it's a refractive error issue. So in other words, the prescription is not available in a daily disposable. Or, for example, with toric lenses, the the stabilization is not as good, maybe, I don't know, in the dailies compared to that's, by the way, not a thing, but that could be a problem. Or, for example, in the monthlies, the torics are available in every degree or every 10 degrees, whatever, and then in the dailies, that's not. You only have, you know, around the horizontal and around the vertical, and you are missing out on the oblique. So it is possible that you just don't have that option.
Okay, that's right. That's really important. And another question, again, we were talking about a lot of options in terms of rewetting drops or dry eye drops. Also, contact lens solutions, there are many options. So, any thoughts on using similar brands or same brand solution with same brand contact lens material? Would it reduce discomfort? Any experience on this? Any thoughts on this?
Yeah, that's a very good question. I don't know that much about the solution itself, if that is really an issue with the contact lens. But what I do know is that the contact lens solution and the lens case is a combination. So in other words, you should not just have a fancy case, I don't know, that you can buy in some sort of, you know, I don't know, in a shop that looks really pretty, and you have a contact lens solution, that those are very often not compatible. So what happens is that when you use a contact lens solution with a case that is actually don't come from the same manufacturer, then you get this biofilm inside the case, and you have a much higher chance of an inflammation or infection because of the non-compatibility of it. So that's more where I was going for. I don't know. I don't think there is that much of an issue by having a contact lens for one manufacturer and then a solution from another manufacturer. I don't think so, because it's the material in the end, how it responds, right? As long as we are giving enough information about how to clean the contact lens, how to use the solution with the contact lenses, assuming that patients will say yes but do no. Just being considerate again, having an open conversation with your patients about this, and rather getting an honest answer rather than a fake fake answer and then see MK next week. That's my
Nightmare.
sorry, I'm not really answering that question very well. I don't actually know.
Yeah. Okay, great. One last question. Again, this is something which you probably like to,
Yeah.
your thoughts. Do you perform dry eye examination for all patients, or only if probably when you do the questionnaire you have some results which you don't want and then you do, or something like that? What's your thoughts?
Yeah. We are currently not doing anymore a standard dry eye check, for example, in primary care. We will be doing that again. That's in the student clinics. But we haven't done that, particularly also because of COVID, because the dry eye clinic hasn't actually run. I prefer to, yes. If I would have my own practice, or when I was practicing before I became a lecturer, we were definitely doing a dry eye questionnaire on all our patients. We had a specific one for contact lens patients, and we had a separate one for the primary care, so refractive clinic. And we would act on it. Then when we were doing slit lamp examination, we would look out for it. We would be looking for the signs. Whether or not we act on it, it's all about communication. So I want to say I performed it normally on every patient. I can imagine that you don't. I don't know if there's a right or wrong answer, because it really depends on your clinic. Yeah. But please remember, if we are only looking when there is a complaint, we are already too late. Not for CLIDE in general, because with CLIDE, patients are symptomatic when they are wearing the contact lens. So we just need to ask the right questions. But for dry eye, I personally think this is going to be an epidemic. I mean, we're talking a lot about myopia management, and I think that is fantastic. I'm really, really pleased that we're pushing that now a lot. But I think with dry eye, we are forgetting that's the next big one, because it's unbelievable how many patients are struggling with it, and they don't even know really. They unless you really speak to them about it, that's when it's like, oh my God, yes, that's what I have. And yeah. Is that answering your question? Sorry, Sam, that's not again, I hope it answers your question.
Yeah, I think, as you said, it's ideally you should be doing it for all patients. And I mean, very truly said,
Yeah.
You can decide on taking steps for management before patient has any complaints. And that's where it's too late. You have to start many options. When you pick up early, you just have to do slight tweaking in your management. But when the patient has complaints, you have to do too many things, and then non-compliance and other things. It's good.
Yeah. So yeah, you're absolutely right. So I run, normally we have the speed questionnaire. Just as patients are waiting in the waiting area before they are being seen. Whenever when you add the number up, if it's over 8, then normally we would discuss with the patient that there is some signs towards dry eye. If they're interested to be seen in the dry eye clinic, they make a separate appointment for that. So there is no further dry eye assessment other than obviously you're checking meibomian gland and blepharitis as part of a slit lamp examination, but you're not necessarily addressing all of that, because this patient, if they have dry eye from this symptoms, then they should be referred to. If they don't want to go to the dry eye clinic, fine, then you can just tell them really quick, warm compresses, supplementation. You try to kind of fit it in. But if they're interested and they're suffering, they are probably quite happy to have a dedicated time with you to just discuss dry eye. And I think maybe Sarah might have mentioned that. You had Sarah Farrand probably a couple of weeks ago about dry eye. So I'm guessing that she might have said something similar. It's kind of like you need that dedicated time. There is no time to do also OCT and talk about the retina and glaucoma and AMD and refraction and dry eye. It's just too much. The patient will not even take it in. It's just, so yeah.
Overwhelming for the patient. So
when they come to the dry eye clinic, I will do the OSDI. I will get a little bit more information about how it impacts their dry eye and their daily activities and so forth. So I'm not particularly looking for CLIDE necessarily. This is actually really specific for dry eye. Yeah, we'll go OSDI, like a better or like a more detailed questionnaire to get a bit better understanding, and then I'll do all the things that you normally would do in a dry eye clinic. Yeah,
that's right. Okay, I think you said wonderfully. I think Ma'am Sarah Farrand also did mention that having a separate appointment is really important, and you also reinitiate the same points that patients get overrun within the same visit. You tell them, okay, you have myopia, and then you also have dry eyes, and they are thinking, oh, should I do myopia or should I do dry eye? So having a separate appointment, and again, it comes to professionalism, and you can also have your professional ethics there, where you can do dry eye as a separate clinic.
Yes.
Good.
Perfect.
Okay, great. So thank you so much. With that, I think we have taken most of the questions which were on the chat. Thank you so much for sharing your thoughts and doing the session for us.
Of course, you're very welcome. Thank you all for coming out. It's brilliant. And I love all the questions. It's great. That's good news, like having a conversation about it. I'm learning every day as well. And I'm learning from you guys. So this is fantastic. It's really, really nice. Thank you for inviting me, Fakhruddin. That's lovely.
Most welcome. Most welcome. So to the attendees, we do have session planned next weekend. And please do join us next weekend. Until then, take care, be safe, and see you next week. Bye-bye.
Bye.
Bye. Thank you. Thank you so much.